ora koutou. Ko Sue Brewster taku ingoa. Hello everybody, my name is Sue Brewster and I am the Executive Director of Auckland Medical Research Foundation. So welcome to you all and thank you so much for coming. I know a lot of you here tonight know about Auckland Medical Research Foundation and see quite a few of our supporters here in the audience. So I just wanted to say a big thank you, and you are really a very critical part of our mission to fund world-class medical research. For those of you who are new tonight, welcome. We are the largest independent funder of medical research in New Zealand. And for those supporters of you that are here tonight, you have helped us to fund over $84 million worth of medical research over the last 66 years. So that's pretty incredible. We do have in place expert professionals that ensure all applications go through a really robust assessment process, and we fund amazing researchers that work across the spectrum of medical conditions and diseases. Tonight, you're going to hear from two of those amazing researchers, Dr. Marie-Claire Smith and Associate Professor Andrew McDade, whose work your support has helped to make possible. Tonight we have the privilege of hearing about incredible research that is helping New Zealanders achieve independence after stroke. Our first presenter is Dr. Marie-Claire Smith, who trained as a physiotherapist specialising in neuro-rehabilitation and has worked with many stroke patients over the years. Marie-Claire's research has focused on TWIST, a tool that predicts with 90% accuracy if and when a patient might walk again. Our second presenter is Associate Professor Andrew McDade, who has expertise in mechanotronics, engineering, don't even know if I've said that right, smart materials, control systems, and clinical research. But when Andrew first started out, he chose a different path from most of his fellow engineering students. Andrew wanted to find ways to use his mechanical knowledge to help people, and as part of a multidisciplinary collaboration, he designed the Relink Trainer. So without further ado, I would like to welcome Dr. Marie-Claire Smith as our first presenter, and then Andrew will take the chair not long after that.
Thank you for the introduction, and it's a real pleasure to be here tonight to talk to you about the research that we've been doing. Basically, I'm going to talk to you about whether we can predict the recovery of movement and function after stroke. And before we even start, we're just going to give a bit of background information about stroke in general. So it is the most common cause of adult disability worldwide, and every year 10,000 strokes happen here in New Zealand, which means at any given time we have almost 60,000 people in this country who are living with the effects of stroke. And given that we're getting better at treating stroke when it first happens, so fewer people die from having a stroke, and the population is ageing, we're expecting the number of people living with the effects of stroke to increase quite significantly over the next few years. So it's a real problem that many people are living with the effects of here in New Zealand and throughout the world. So what is stroke? It is the sudden onset of a neurological deficit that lasts for more than 24 hours, and it's the result of a disruption of blood flow to the brain. Most people have what's called an ischemic stroke, and about 20% of people will have a hemorrhage. So this is what a hemorrhagic stroke is. If we have a look at this picture here, you can see the blood vessels coming up from the heart, and then supplying the blood, which provides oxygen and nutrients to the brain. And a hemorrhage is when you have a leaking or a rupture in those blood vessels, and you end up with blood in the surrounding tissues. The other type of stroke, the ischemic stroke, so that's the more common one, is due to a blood clot. So that's a clot within the arteries that are supplying the brain. And this picture here, you can see that the clot is in one of the little arteries. So it's one of the smaller vessels, and that means that the amount of brain supplied by that or damaged by the stroke is relatively small. If somebody has a stroke on one of the large arteries supplying the brain, like this one here, you can see that there's a huge area of the brain that is relying on that blood supply to stay alive. So one of the things that is quite interesting to see is what a scan of a brain looks like for somebody who has had a stroke. This is an MRI scan. What we're looking at here is basically a slice through the head, and as if you're looking down on the brain. You can see the white surrounding it, that's the skull, and then this black area in the middle, these are called the ventricles, and that holds the fluid that sits around the brain. You can also see that it's quite wrinkly around here, and that's basically, whenever you see a picture of the brain, it always looks like a sort of wrinkled walnut. So that really is what it looks like. And then these grey parts are the grey matter, and the white parts are the white matter. And the grey matter essentially is the neurons or the nerve cells, and the white matter is the connections between the pathways that allow the brain to talk to different areas and also to communicate with the rest of the body. In this case, you can see that there's this big area here that doesn't look like the rest of it. So that's a really large middle cerebral artery stroke. Now, if we look at another picture of the brain here, we can't see the ventricles here simply because we're at a different level of the brain, but here is a stroke here. So you can look at that and say, well, that's not very big. They're probably fine, because commonly people think that we only use 10% of our brain, and so if something happens to a little bit of our brain, the rest of it will just take over, all become super geniuses. The reality is that we need all of our brain. Every part of our brain has a specific function. This here is the part that controls the hand and the arm. So for somebody with a scan like this, we can expect that most of their other movements are going to be fine, their talking is going to be fine, but they actually have a significant disability in relation to their arm. They may not be able to move it, and there isn't actually another part of the brain that can just come and take over that job for it. What is useful to take away from these pictures is that size is important, so a big stroke is bad, but a small stroke in the wrong place can be just, quite devastating as well. You may have heard of the phrase, time is brain. It's quite literally true. For every minute that the brain is starved of oxygen, 2 million neurons will die. That means for every hour before we get blood flow back into the brain where it's been restricted, on average, people will lose about 3.5 years worth of neuron loss that you would normally lose over a normal aging process. And this is what we're looking at here. So what happens when you first have a stroke is you have this part here, which is called the infarct core. So it's a part of the brain, the cells are already dead or they're dying, so they're not salvageable. Then you get the blue area around it. And what that area is what we call the penumbra. So it's the part surrounding the brain that has not got very good blood flow at the moment, but the brain cells are not dead yet. So the sooner we get the blood flow going back into that area of the brain, the more of those salvageable cells will survive. So you can see here we've got a time frame here. It's just an example, but you can see over time the number of cells that actually die as a result of the stroke increases if we cannot get the blood flow back. And this is my community service announcement. This is why fast is important. This is why time matters. So the Stroke Foundation message, which everybody has probably, hopefully heard of, if somebody has face weakness, if they have arm weakness and a disturbance of their speech, it doesn't have to be everything, just one of those things, then calling an ambulance and getting to the hospital is absolutely essential, because the sooner you get there, the sooner treatment can start to try and reduce the impact of the stroke. So what happens if you come into hospital quickly? Well, about 20 years ago, nothing. There was nothing that could be done for people who'd had a stroke, apart from wait for the effects of the stroke to do their thing and then start rehab and try and do the best you can. Shortly after that, they developed a new clot-busting treatment. So you might have heard about that. So essentially it's a medication that slowly dissolves the clot. But that's quite a slow process, and it didn't work for everybody. And if you have a very large clot, then it takes too long, basically, to recover. A lot of very advanced stroke research was happening about 5 to 10 years ago. And what they did is they developed a treatment called clot retrieval. And this was done through Auckland Hospital was one of the sites, along with several other international sites. And they had several major international studies looking at clot retrieval. And essentially what they're doing is they're literally going in and pulling the clot out of the brain so the blood flow can be restored. So I'm going to show you what that looks like now. If you don't like blood or you're squeamish, there will be a picture with some blood on it quite shortly. So what we've got here, this is a picture of a blood vessel, so it's what we call an angiogram. It's showing the blood flow into the brain through this artery here. And what happens is the artery splits in half here, so this part's supposed to supply one part of the brain, and then there should be some blood vessels here, and you can't see them. So that's the part of the brain that is not getting blood supply. So what happens is a patient, if somebody comes into hospital quickly, they get seen in ED, they get screened very quickly, and they get rushed, if they're suitable for this treatment, they get rushed off to surgery. And they put a wire in their groin, and then they feed it all the way up through their arterial system, all the way into the brain. So that is what you're actually seeing here. This is a little wire that's coming up here, and you can see even by putting the wire in, there's a little bit more blood going through. Then what they do is they either suction out the clot and then literally unfeed the wire again, or they use a sort of metal cage, it's called a solitaire stent, to expand and grab onto the clot and try and pull it out. And in this case, it was extremely successful. So you can see there that blood flow has been restored. Timing is still really important because you want the blood flow to be restored as quickly as possible to salvage as much brain as possible. And here's a squeamish photo if anyone doesn't want to look, but that's what the stent looks like. So it goes into the clot and then expands and then comes out. So this procedure was developed internationally, and New Zealand was a really part of the international research group led by Professor Alan Barber, and he leads the clot retrieval service within New Zealand. As of 5 years ago, clot retrieval is now available for patients at the hospital, and it's available in Auckland, Wellington and Christchurch. So patients from other centres get flown in to these main centres to have clot retrieval, and we do about 350 of them a year, which on an international standard is world leading. The thing is that not all patients are eligible, and if you think about 350 of these procedures versus 10,000 strokes, you can see that there's a real mismatch in terms of how many people can actually benefit from this procedure. I just want to say that those people who have it, when it is successful and the blood is restored, blood flow is restored very quickly, it is, can be a very dramatic recovery. So we get people come in who are completely paralysed down one side and can't talk, and they may well walk out the door a few days later. So it's the biggest change in stroke treatment ever, basically, in terms of the impact that it has. But again, it doesn't work for everybody, and not everybody is eligible, which means that there are still a whole lot of people living with the effects of stroke. So what we've been talking about is the acute treatment, and it's all about restoring blood flow to the brain. Once you're over that very acute phase, so the medical side of the stroke has happened, we need to move on to the recovery phase, and that is about the brain itself. So one was about the blood flow, this one is about what can we do to help the brain to recover. And this involves strengthening connections, creating new connections within the brain, and really learning to get back to previous activities as well as possible. And for many people, and we've got a couple of these people in the audience tonight, so thank you very much for modelling for us. That involves rehabilitation. So this is some of the physio rehabilitation happening across the road at Auckland City Hospital. For some people, that they may need a harness to help take the weight off while they're walking, and ultimately the goal, obviously, is to be walking by themselves. In order to do good rehabilitation and to make sure that the rehabilitation fits the person that you're actually working with, it really helps to know a little bit about their brain and their potential for recovery and what will be good for them. And that's why making predictions about people's recovery is helpful. It means that we can tailor the rehab goals, we can manage patient expectations, so we can start to talk about what is it like to live life after stroke. We can use time and resources to bring the best outcome for the patient. So it's not just our time and resources, it's also the patient's time and resources. After a stroke, many people feel absolutely exhausted. And it's important that what we're doing with them is going to create the biggest benefit for them. There's no point doing things that are not helpful. And then early planning, so knowing a bit in advance how long things are going to take and what things are going to look like helps people to set up, start getting ready for going home and leaving hospital. One thing I just want to say is prediction should never be used to withhold treatment from somebody. Prediction is there to support rehabilitation. So everybody who needs rehabilitation gets rehabilitation, but what it does is it enables us to focus on the type of rehabilitation that is going to be the best for that individual person. So the question that I had was, how good are we at predicting recovery of the hand and the arm and walking after stroke, and asking whether patients get given this information and whether clinicians actually know. And there's a study that they asked 20 clinicians to tell them how well they thought their patient's hand and arm would be working at 6 months after the stroke. And it was about a 50-50 coin toss as to whether they were accurate or not. We also asked some clinicians to predict when they thought their patient would walk by themselves after stroke, and we found that about a third of the predictions were correct, about a third were a bit too optimistic, and about a third were too pessimistic. So again, it's a real mixed bag. So what is the problem here? Why is it so difficult? It's because when we see two patients, they can look very similar from a clinical point of view, and then they end up in completely different places further down the track. And so when we rely on clinical intuition alone and experience, then we're missing out on some information about what's happening in the brain itself. What we've got here is a graph. Along the bottom is a number of weeks since they had the stroke, and along here we have a test for the hand and the arm, and it's out of 57. So 57 means they've got good movement, and 0 means they've got no movement at all. Each of these lines is an individual patient, so that's tracking their recovery over those 6 months. If we look at two people that were about in the middle of the hand and arm scale, we can see that one of them made almost a full recovery in green, and one of them made very little improvement. If we look at two more people who are a bit more severely impaired, you can see again one of them did really well and another of them made very little improvement. They looked the same at baseline. And then again, if we look at two people who basically had no movement in their hand and arm at 2 weeks after the stroke, one of them got to the point where they could use their hand and the arm in most of their daily activities, but a bit slowly and a bit more clumsily, while another one still had no movement at 6 months. So there's something else that we need to know, and that is a little bit more information about what's happening in the brain. Specifically, we need to know about how much damage there is to the pathways that take messages from the brain to the arm and the leg. And there's two ways we can do this. One is to find out whether those pathways are still working. So can we get a message through from the brain to the arm and the leg? And we do this with something called transcranial magnetic stimulation. Essentially, you can see it in the picture there, we hold a coil against the head, it delivers a magnetic pulse, and it gets the neurons in the brain excited. They try and send a message down and to the arm and the leg, depending which site we're stimulating, and then with some sensors on the arm or the leg, we can identify whether that message was able to get through with this trace here. The other thing we can do is use an MRI scan to have a look at the brain, so some of those scans that we looked at beforehand, and see where the motor pathways are and how much of those motor pathways are overlapped by the stroke itself. What we know from these two things, out of these two options, the important one is actually this one. The important one, the one that matters in terms of hand and arm recovery at least, is whether the pathway works. It doesn't matter what it looks like. So it really doesn't matter that much what it looks like on MRI. It matters whether the brain can get a message through to the hand and the arm. So using that tool, some of the research that our group did earlier over the last 10 years or so was developed in a prediction tool, a decision tree, that can help clinicians identify how well their patient is going to be using their hand and their arm by 3 months after the stroke. And we do this First of all, with two simple movements. Ask the patient to lift their arm up like so, and ask them to straighten their fingers out. Both of those are scored out of 5, and then they're added together for a score out of 10. If they score 5 or more, and they're young, so in our world that means under 80, then we expect them to do very well. If they're older, they actually need to be a bit stronger at the beginning to have that same outcome. For people who are quite weak, so they've scored less than 5, this is when it's really important to know how well those pathways are working, and we use TMS. If we can get a message through, so we get that nice wiggle that you can see on the screen, that tells us the pathways are working. They're probably a bit damaged, but at least we can get a message through. That's good news. And it means that we can expect these people to do fairly well. They're not going to be as good as they were before they had the stroke, but they should be able to use their hand and their arm by 3 months for most of their activities. If we can't get a message through, this tells us that the pathways are severely damaged. In this case, we look at the overall severity of the stroke, so what other parts of the brain have been affected, and taking into account things like speech and overall movement, thinking, and so on. This determines whether they have what we call a limited recovery, so they can do a bit with their hand and arm, but they usually need 2 hands to complete the task, or a poor recovery, which means they're unlikely to get much movement back here. This algorithm is accurate for about 75% of people, and it's been validated. So what that means is that the research was done here, and then it was tested out again in a whole new group of patients, so that to make sure it was accurate and before it was used with people in the hospital. So the stage that we're at now is that any patient who comes into a hospital in Auckland or Waitemata DHB with a stroke and weakness in their arm gets given this information. So they go through that process, and if they want it, they get provided information about their likely recovery of their hand and their arm. This service is not led by us in the university, but by the physiotherapists and occupational therapists in the departments. And the information is for the patient, for their whānau, and also for the clinical team, so they can work together to get a good rehab plan going. We have other DHBs around the country who are getting ready to implement PrEP too. So this came from health research, stroke research. We've developed this tool. Now patients and clinicians are able to use it, which is really exciting. How have we done this? How did we get from research to actually something actually working in a clinical setting? Quite often research happens and it never reaches what we would call end user. It never reaches the actual patients for which it was designed to help. And part of the reason is that we do our research in the hospital. So all of our work is in the hospital, and it means that as we're developing new tools, that we are making sure that they work within the hospital and that they're valuable so that patients and clinicians want to use them. Does anyone want to hazard a guess as to how long it normally takes for something that's published in research to then be used in clinical practice? 17 years. So, yeah. So the 2 bits of research that I've just talked to you about, so the stroke treatment where we pull out the clot, I say we, but it's Professor Alan Barber and the team, not me at all. They pull out the clot, and this prediction tool that can help people to plan and do more effective rehab, that got into practice within 18 months. And so that's what we're really very passionate about, is that whatever we are doing has to be useful, and it has to be something. We have to work hard as the researcher to get that actually working in the real world. So that's really important with all of our research. So that's the arm. And now we're going to talk about the leg. So can we do the same thing with the leg? And this is a more recent study. And we had 3 questions here, which I think are all very important. One is, do people want this information? The second one is, how accurate are the physios here at making those predictions about walking recovery? And then finally, can we develop a tool that is actually accurate at predicting walking recovery? We had 124 patients that we recruited within the first week after their stroke, and they were from 2 hospitals in Auckland, so Auckland Hospital and North Shore, and a handful from Waitakere as well. And what we did is some assessments right at the beginning to identify, well, what are the important things that will tell us how quickly this person's going to recover, and then we followed them up to identify if they achieved independent walking in that 6-month period and how long did that take. So here's what we found. We asked patients in whānau whether they agreed, disagreed, or whether they were unsure about the following statements. So the first statement is, I want my care team to tell me whether I will recover independent walking. Do you want to know whether you're going to walk again or not? In green is the number of people who agreed with that. In orange is the not so sure, and then pink is disagree. And I think the important thing to know about anything prediction information is that if you don't want to know it, you don't need to know it. But I think it's our job to make that information available if we have it, and then it's up to the person and their family to make that decision. You can see that pretty overwhelmingly people want to know. The second question was whether I want my care team to tell me how long it will take me to get back to walking by myself. And again, very similar response. And then the third one was asking them whether they thought having this information would be helpful in planning to get out of hospital. And you can see there's quite a difference here between how many patients thought it would be helpful and how many family members thought it would be helpful. And I think this is a reflection of the fact that the burden of planning discharge from hospital lays heavily with the family member. It's up to them to have to work out how we're going to support this person, and the patient's often very worried about discharge, but the details are often up to the family member who's supporting them. And I think it's something that we try and remember all the time with stroke, is that it's not just the person with stroke, it's the whole family unit that is affected by this problem. And then, as I said before, we asked the physios to make their predictions. We asked them to say, do you think your patient will be walking at 4 weeks, 6 weeks, 9 weeks, 3 months, or 6 months after stroke, or will they not be walking by themselves yet at 6 months? Along this side here is what the physiotherapist predicted, and along here is what actually happened. So you can see the lines moving through. So if you look at the bottom bit here, pretty good at identifying those people who are not likely to be walking by themselves by 6 months. Also pretty good at working out who was going to get there really quickly. But everything in the middle is just a big schmozzle. So it's really difficult to sort of sort out that middle group. So then it comes down to, did we find a good prediction tool? And the answer is yes. The good news is that for walking, we actually don't need that test of the movement pathways, and we don't need MRI. So this makes it a quick, simple to use tool that's really cheap and easy to train people up for. The stage that we're at the moment is that we have developed the tool and now we're testing it across the road at Auckland Hospital. And the reason I can't tell you exactly what is in the tool is there's an entire row of Auckland Hospital physiotherapists sitting up there who are involved in the study, and if we tell them exactly what the tool is, it will change their therapy behaviour, and we no longer have a blinded study. We can't validate it, so we need to validate it. We validate it, so we test it out for accuracy in a setting where nobody actually has the information. But I can tell you some things. That is that we don't need TMS and we don't need MRI. We just need 4 really simple and quick clinical assessments combined together with different weightings to get what we call a twist score out of 5, so 0 to 5. It makes accurate predictions for most patients. It's about 90% accurate. And the kind of information we are hoping to be able to give people is this sort of thing here. So it says almost everyone with this score will achieve independent walking within 6 weeks, and about 3/4 of people will actually get there quicker, so they'll get there in 4. And so there's a bit of wriggle room because not everybody's going to do exactly the same thing, but it gives people a good idea about how long is it going to take me to get back on my feet. This is essentially what we're using, which is a bit of a traffic-like system. So the twist score is down here. 0 is bad, 5 is best. And red means that they're unlikely to be walking independently at that time point. So you can see the time points at the top. Orange means there's some chance of walking independently, and green means that they're likely to be walking independently. So as an example, if we take a twist, somebody who scores 2 out of 5 on their twist score, we can see that they're unlikely to be walking independently within the first 6 weeks of their stroke. There is a chance they'll get there though within 12 weeks, and they're almost certainly going to be independent by 6 months. So it gives a good idea of the time frames. and the same applies for the other schools as well. I just want to come back to a bit of a summary as we're rounding off and just talk about what we've achieved, certainly in stroke research here in Auckland. We're leading the treatment for acute stroke, or hyperacute stroke we call it, which is the very, very early treatment with clot retrieval. We've developed prediction tools for hand and arm recovery and also for walking recovery. And the walking recovery one is not ready for clinical practice yet, but that is the study that we are currently running to make sure that it is accurate and ready to go. We've published in the leading stroke and rehabilitation journals with all of this work. And then what next? Continuing to build clot retrieval capacity in New Zealand is a huge goal for stroke network in New Zealand in general. At the moment, Auckland, as I said, Auckland, Wellington and Christchurch are where the treatments happen, and of course people from other centres have to get there really quickly in order to have access to the treatment. So they're being helicoptered, but there's a lot of ways that they're trying to make that happen more quickly. For example, if you are in Auckland, anywhere in the wider Auckland region, and you had a stroke, they will take you directly to Auckland Hospital if there's a chance that clot retrieval will be good for you, rather than going to North Shore Hospital and then across, or Middlemore. So there's a central place to have that happen. We're implementing Prep2 in practice, so that's already happened, but we're doing it in other places in New Zealand and also several centres around the world. And we're in the process now of validating the TWIST tool so that we can implement that. Once we finish the current study that we're running, we're also asking for the study how patients and whānau feel about information and how they want it delivered, and we're asking the therapists as well. So by the end of this study, we will have the TWIST prediction tool and also the best way to deliver that information according to the people who are actually going to be using it. That's all from me. I just want to say a huge thank you. Thank you to AMRF and all the donors who contribute to medical research. Of course, the research team, there is a lot of research and a lot of people behind all of this research. We can't do any of our research without support from the local DHBs. So particularly Auckland and Waitemata DHBs, we thank you, the staff, because without you guys, we could not do it. And I think last and most importantly, we really thank the patients and whānau who are involved in our stroke research. It never escapes me what an amazing thing it is. We see people within just 3 or 4 days of possibly the worst experience of their life, when they're very vulnerable, something really horrible has happened, and yet people are willing to listen to us, to be involved, to be part of research that will help somebody else in the future. And it just blows my mind that people are so kind and willing to be a part of it. And so we're always very, very grateful. Thank you.
Thank you very much, Marie-Claire. Marie-Claire was awarded a postdoctoral fellowship through the support of AMRF donors last year, and has also achieved a part-time lecturing position as well. So all of that research and all of that hard work is really starting to come to fruition. We would now like to welcome Associate Professor Andrew McDade, who is going to talk to us about his Relink trainer.
Good evening, everyone. Thank you for coming out tonight. Thank you for the donors for helping to support this research. So tonight, what I'm really going to be talking about is a lot of the robotics and the technology research that we've been doing, focused mainly around stroke and this Relink trainer, which is here, and definitely welcome people to come down and have a look and have a turn with it after. But also more broadly, some of the other projects we're working with. You know, I think this is very timely with what's going on with COVID and the need for new technologies. You know, a lot of healthcare resources are now being used to deal with the current issues, and a report coming out from the World Health Organization is really, pre-COVID, is saying that with the way the demographics are going, there's really need for this labor-saving technology. So the idea of robotics, telehealth, and these sorts of tech. So just quickly, a background on myself. So I'm a Kiwi, was born and brought up here. That's not me in the picture, that's my 3 children. But growing up, I was always interested in technology, always building things, and that's what really got me into engineering. Coming from a big Irish Catholic family, we were always encouraged to help other people, and I guess that was sort of my spurred on my interest in medical interventions and helping other people. So inspired to go down this track of developing new technology. So I'm very fortunate to have a position at the University of Auckland, a big research team that has done a huge amount of work across a number of different projects, which we're going to share some of them tonight. Carrying on the theme as well from the earlier talk is, a big part of what we do is trying to do this translational research, more than just research in a lab and publishing papers, but actually getting this out. So a part of that as well is, founding companies that are actually looking to translate this technology and give it out to access to patients. What really drives me is actually taking, fundamental research, building technology, and then getting health outcomes. So not just looking at the technology, but actually looking at the science behind that. We're really driven by this triple healthcare aim, which I'm sure some people are familiar with here in the audience, but it's really this aim of course, improving population health, so improving patient outcomes, but also the experience of care is huge. So experience of care for both the patients and also for the clinicians as well. So having technologies that actually make delivering care more, improve the experience of doing that. And the third one, of course, is reducing the cost of delivering care. So, of course, technology has costs. So how can we develop the technology to reduce the overall cost of delivering healthcare, reduce healthcare utilisation? The topics I'm going to cover today is, I'd like to share this sort of framework that we've developed around how we believe robotics can actually help for rehabilitation, especially in the sense of physical human-robot interaction. The second part is just to go through a selection very quickly of some of the devices we've developed to give you a sort of flavour of the things we do and the applications. But the big focus tonight is really on this Relink Trainer project and to show the evolution of that. And I was not too disappointed, well, I should take that back. It is disappointing to see that it takes 17 years to translate it, but we're not doing too badly in that as well. And then, just finally some thoughts about translation of research and how we can actually increase patient access to these technologies, which is really important, and just some forward-looking thoughts as well. Our research really is around using robotics for 3 different areas. So the first one being therapy. So in therapy, broadly speaking, there is impairment-based therapy, which can deliver things like stretching, strengthening, range of motion. And then there's functional therapy as well, so gait and so walking and doing more functional tasks. Assistance, we do a bit less of this, but this is, again, we can use robotics to help to replace some functionality. And then the third area is diagnosis. How can we use robotics and technology to capture data and really see how well the person is doing, and then again making better interventions and goal settings and things. So I'm just going to step through this framework, and excuse the fact that it's quite engineering focused, but I hope that it does, we're used to thinking graphically and in block diagrams. At the core of what we do, we still believe, of course, that the clinician has to be called the clinician, and the patient are really the center. So that relationship is the most important. So then we start to see, okay, well, what can we do with robotics? So robotics have sensors, so they can sense what the patient is doing. They can sense the movement of the patient, the forces, the muscle activity. The robot can also interact and provide forces on that patient as well. So then when the intelligence comes in, we need a feedback. So we need a controller which tells the robot how to act. So basically it uses those sensors to then decide what action to take. So that's what we call a feedback controller. With those components, the system would be very boring. It wouldn't really be that interactive. So then we say, okay, well, we need some sort of interface for the patient. We need some, potentially a game or some way to drive their interaction with that system. We then, of course, need the clinician to be involved in that. They need to be able to set how advanced the patient is, how aggressive that rehab might be, those sort of parameters. Another big part that we see as well is how we can integrate this technology into the operations side. So there's a user interface, a portal for the clinician. There needs to be integration with clinical records, and also this idea of goal setting as well. So this is more the operations side. An interesting area that we've been working on as well is how we can actually use models and simulation of the person, so we know their geometry. We also have some sensing, so how we can build models of that person to detect physiological parameters. So that might be things that you can't directly measure, like muscle stiffness, the damping force of the muscle. So actually some of the underlying parameters, which we can then use again to feed into this therapy prescription. So if you break it down, we've got this idea of, delivering robot therapy, which is one piece. We also have the assessment piece and then the operations piece as well. So to go through some more concrete examples, we've developed, a number of different exoskeleton technologies. So exoskeletons being sort of wearable robots. This here is an example of a elbow exoskeleton, originally designed for patients with cerebral palsy to do more reaching tasks. So it can be used, it has motors that drive the joint, so it can be used for resistance, strength training. It can be used for assistance to help people reach out. And we've gamified this as well. So you can play games and interface with your therapy tasks in that way. We developed a really simple game for children with cerebral palsy, and again the idea is that we can assess where they're strong and where they maybe need some work, and we can place targets for those games. So this one here was a frog game where basically they got caught by the frog, and the frog would provide then resistance to that exoskeleton. We've expanded it to the wrist as well, so the wrist is a bit more complicated with two degrees of freedom, but again we developed exoskeleton for that and applied that in the cerebral palsy population. We've developed more treadmill-based exoskeleton technologies. These ones here are obviously lower limb. We've utilised soft actuators, even though these definitely don't look soft with all the metal involved. The actuators being, instead of motors, we use pneumatics, so they're quite soft and they provide a bit more natural interaction, which is one of the challenges for robotic training. And on the right there, we've got a wrist exoskeleton as well, similarly using these smart material technologies. We've also looked at the potential for, if someone has a stroke and if they haven't actually lost the limb, their muscle is still there. So, this is taking the idea of actually using the muscles, their own muscles, as the actuators for the exoskeletons and actually stimulating. So we use, neuromuscular electrical stimulation to stimulate the muscles to provide this sort of neural prosthetic. So this is for people that potentially have paralysis or some sort of muscle weakness. We can actually stimulate the muscles in the forearm to give them some grip capability back and train grip as well. This here is another example with the CP population. We developed a sort of therapy and diagnosis system for children that were having Botox injections. So Botox injections are a common intervention for very stiff muscles, and it sort of releases them and provides some additional movement. It started off being used off-label, and so we really wanted to get to the fundamental science and start to look at what effects do these injections, does this intervention have on the underlying muscle properties. So we built some test rigs for both the calf muscles and also the elbow muscles is there. I'm going to dive in a bit deeper about this Relink trainer, which is the project that was funded by AMRF, and is just a really good example of how some of these projects come about. So the history of this one was, as a young engineer starting out in this field, I'd done some work with these more elaborate exoskeletons, and I was looking for collaborators from, the medical school, and I reached out to Jim Stenier, who's a movement neuroscience scientist. We had some, a really good discussion. He sort of was talking from the, his background in neuroscience, and he sort of brought up this idea that he'd been thinking about for a decade or so and hadn't really had the chance to test it out. And the point of this was he had this hypothesis, and it involved a whole lot of really technical neuroscience terms, and me coming in as an engineer, we were just talking different languages, I guess. Over the years, I've been able to understand slightly more than what I did back then. But I guess the point is, just this importance of having the fundamental neuroscience background, where he was talking about, having a kinematic constraint at this acute stage of stroke, neuroplasticity and reorganization of neurons and synergies and all this sort of stuff. And I sort of walked away from that meeting thinking, well, so the idea is if we can stop people learning to walk badly, then they're going to hopefully have a better outcome. And that's sort of where I went with this idea and took it and ran. We both sort of agreed, and he was very strong on this point, the simpler the device, the better. So that was really what was drummed into me. Over the years, I didn't just take Jim's word for it. We also were following a lot of the clinical evidence as well. There's been systematic reviews of quite a number of randomised control trials, which is supporting the use of robotic gait training for post-stroke, suggesting that patients are more likely to achieve independent walking with robotic training. These reviews also noted that subacute and non-independent walkers benefit the most from robotic gait training. But what we found was that the robotic studies weren't being done in acute stroke, and only a few of them were using mobile over ground devices, and only one of them included dependent walkers. So this is where we were sort of like, okay, we might be onto something here. I think what we didn't realise is the reason why that's the case is because it's really difficult to work with acute stroke patients and have overground gait training. But it was something that we were looking to tackle. And another important point there as well was a separate review was showing that this overground training, it shows more promise than treadmill training. So looking at the history of then how we sort of went about this, I had some summer students and some final year projects that we got onto this straight away. Myself and Jim had sort of broken this down into 3 stages, and we said, okay, we'll do the engineering proof of concept first, where we started this team back in 2013. We got some funding from the university to do cross-department collaboration. Stage 2, which was obviously a really key part of this, was the AMRF funded project, and that was really the catalyst that took it from the engineering through to the clinical side. So, and also helped us grow the team. We had Sarah Ward, who was a PT, to come in, so that was bringing the multidisciplinary side. Kathy Stenera as well, a clinical neuroscientist, was instrumental in taking this from stage 2 to stage 3. And also bringing in the ADHB as well. And then phase 3, which we completed recently, was an HRC feasibility grant, which tested the feasibility of taking this technology and actually applying it in the acute stroke setting. So just to walk through some of the early images, which I'm a little bit embarrassed about, the quality of these designs. Looking at the evolution, we were saying, simple was key, so we said, we want to move away from an exoskeleton which has lots of different joints and is complex. This gait is very repeatable, so let's try and think of something more mechanically simple. So we went for just a foot plate design, so a design that would just lift the foot and place it. We wanted it to be overground, so then we thought, okay, well, it has to be inherently stable, so having a walking frame made sense. We experimented with a lot of different mechanisms, mechanical ways of actually generating accurate gait pattern. We landed on a linkage design, which is, this is a 4-bar linkage. We did some, mathematical optimization. This picture here is showing the 2 sort of fixed links, and there's all these different letters here represent different parameters that have to be optimized. So we ran that through a mathematical model and iterated until we got to a design which had the correct link lengths to give us this desired pattern, which is basically how the foot plate moves relative to the overground device in order to lift the leg and place it in front. So then the final thing was thinking about power, and again, motors, hydraulics, we tried all these things, and the idea was always that it was going to be, no external power. So we said we were going to not power this, have any external power sources, which would make things more simple, easier to operate, safer to operate, all those things. This here was, the overall evolution of the devices, but the key in the powering of these devices was this idea that we could use the wheel as you push the device, driven by a chain or a belt drive, to drive this linkage. So basically it just lifts the foot, takes a step for the person. So they would have a step with their unaffected leg, and then their paretic leg would be helped through the gait pattern with the device. So this here is a video which is showing this. So this here is in our gait analysis lab, and this gentleman here is a chronic stroke patient. Has been set up with markers, so we're monitoring all his biomechanics, we're monitoring the muscle activities as well to see what effect this has, and getting a whole bunch of feedback on the mechanical design as well. So you can see there his left leg is the unaffected leg, and his right leg is being helped through that pattern. So that there was part of stage 2. There was a few different aspects to this research project. It was really the biomechanics side of the evaluation. It was about building a relationship with Auckland City Hospital, conducting safety analysis, also looking at the manufacturing and running the feasibility study. I won't go into detail into these results, but this here is just an example of the gait analysis that we did with the device and without the device, and we saw the effects. One thing that's quite maybe more straightforward to point out, which was what helped us in some of our designs, was you could see, so this here is left leg, right leg, walking without the device and walking with the device. So one thing that we saw was that, it really had quite a big effect on the ankle trajectories through, and that was to do with the design of the foot plate. So then we used that information to then, improve the design of that foot plate. So then stage 3, which was just completed now, was the feasibility study, and again, really, grateful for the help that we've had from the team at the Auckland City Hospital, and also Kathy's team as well, and actually getting this into clinical practice. We had 12 patients and 6 physiotherapists involved in the study. In the end, we concluded that the idea of the feasibility study was to prove that it was safe, so there were no adverse events, which obviously was a success. The majority of the patients and the therapists found it easy to use and were positive. We also found that we would need to recruit around 100 patients in order to do the full RCT, in order to get enough power for the study. And importantly as well, the recruitment rate was about 12% of patients admitted over that 8-month period. So we had about 100 patients that had come through and were assessed for eligibility, which again has fed into some of the future thinking. So the next steps for the relink, we're still going through and evaluating both the quantitative and the qualitative evidence from that feasibility study, considering things like usability, comfort, not just the safety is one thing, but also the confidence of how well the patient feels, how comfortable the clinicians feel. Looking at the engineering design, like is this really a feasible design? Is there ways we can improve it? Symmetry of the gait was one thing that was brought up. Could we improve the design to provide a more symmetric gait? The applicable population is another really pragmatic thing we need to look at. So with an intake of around 12%, it's starting to us to reflect on what proportion of the stroke population would this device be suitable for. So again, some food for thought there as we go forward and look to a pathway to a full RCT. So yeah, that really brings me on to the final topic I wanted to touch on, which is about this idea of translation. The whole purpose of what we're doing is trying to increase patient access to this technology. So especially with a lot of these robotic systems, there's quite a lot of potential barriers to even getting it from a successful clinical trial into a scalable rollout to patients. So everything from regulatory approvals to the data and privacy that needs to be considered with some of the robotics we're working with, and very importantly as well, the insurers, the payers, the reimbursement, all these different things need to be taken into consideration in order to be actually scale this out. In our lab, we've been through this with one of our technologies. This here is a tele-rehab tool, which is a monitoring device that fits into either a knee brace or just a knee wearable for people. It's focused on everything from sports injuries through to arthritis, knee replacement, and stroke as well. So it delivers home exercise plans, it collects data, it delivers educational modules, it feeds all that information back to the clinician as well. But again, this technology was really developed with this philosophy of looking at the technology from the standpoint of how can we get patients to access this. So a big challenge with the robotics is actually the cost of the devices and being able to scale that out. So looking at how we can potentially make more low-cost device more ubiquitous to get more people using these technologies, and then really learning from that, and then upping the sophistication of some of these interventions. So just some thoughts on the future of healthcare, which I touched on at the very start. With everything going on, this report from the World Health Organization was out long before COVID, but it really identified telemedicine and labour-saving technologies as one of the keys going forward. Really, the way that we're thinking about this is, robotics is all about automation. Data is obviously very important to understand the efficacy of these interventions and help to improve the interventions. A real strong point that we believe we have is that the clinicians are obviously still the real key stakeholder in rehab. So, we really need to be developing these technologies with the clinicians at the centre as well as the patients. And, I guess, engineers are problem solvers, so I know that there's no shortage of problems to be solved in healthcare. So I just think that, us as engineers should be, working a lot more closely with clinicians and developing technologies and translating them. So yeah, just some acknowledgements to some of the collaborators. Of course, to all the students and postdocs, this is just a subset of them. That's the AMRF, all the donors, and again, participants and families who have been, very kind to come in and partake in some of these, quite extensive and time-consuming studies that we've been doing.